is a anesthesiologist, double boarded in interventional pain management, who has done a lot of work in the use of autologous mesenchymal stem cells in disc, also involved in device development for the use of stem cells in disc. As I had said before, sprinkling magic stem cells over something generally doesn't work real well. And what John's been really trying to focus on is how to specifically deploy cells into the disc to make that procedure effective. So, John Schultz.
Thank you, Chris, for that very kind introduction. I'd like to thank everyone that made this symposium possible. This is a first of its kind, and I'm absolutely thrilled to be here. This Colorado slide pretty much epitomizes our last 4 years together in our clinical practice. The pitch has been incredibly steep, the edging, without a doubt, uncertain. But at the end of the day, it has been fantastic. What I'd like to do over the next 15 to 20 minutes is share with you descended, the mogul fields we've traversed, and the absolute champagne powder. What I'd like to talk about is the regenerative therapies for lumbar degenerative disc disease. As Dr. Centeno discussed earlier, it's not about putting magic dust. It's about looking at the patient as a whole. Regrettably, the current concepts and the current approaches do not appreciate that. Regrettably, they're a focused approach. They emphasize quick fixes. In our locale, and maybe like yours, there seems to be a high predilection for surgical intervention. But there's oftentimes not much discussed about the morbidity and complications. How many of your patients have gone on to a surgery that you recommended to go see a surgeon only to come back worse off? Not only do I feel like I failed the patient, but it's also their family that's impacted. In addition, if we look at it a larger picture, I think in many ways that the therapies that are currently employed advance the degenerative cascade. So I propose a new approach that takes the focus from a macro to a micro to a macro. You know, Sister Anne in parochial school was probably right. She taught biology and she was pretty mean with the ruler on the knuckles. But she did tell us that the knee bone was connected to the thigh bone, which was connected to the ankle. It is all interconnected. We also have to be investigators and ask the critical question, how did we arrive at this point? How did this disc become degenerative? Not just treat the problem, but ask how we got there. So our goal is using advanced, minimally invasive tools. What needs to be done to optimize function? You've seen this slide before. Dr. Centeno showed it to you, and I use an acronym for teaching purposes, SANA, S-A-N-A. And these are the cornerstones that we use to evaluate a patient. Just like Dubin used a very easy paradigm for me to read an EKG, we would set this forth to evaluate all joint patients. We start at the top with stability. We look at neurologic function, alignment, and articulation. So let's do a couple examples. Now, this is an MRI of the lumbosacral spine. It's a little dark, and I apologize. But I'd like to systematically walk you through this so you can better understand what we're talking about. Stability, articulation, alignment, neurologic function. And I'm going to go through each one of these because it's a comprehensive approach. Putting the cells in one place is not the answer. But let's get to the basics first. I look at MRIs every day, but I want to make sure you understand the basics so we can appreciate the subtleties. Here's Netter's diagram, the vertebral bodies. They are the building blocks of the lumbosacral spine. In between each of the building blocks is a cushion, the intervertebral disc. This is mirrored here in an X-ray. Once again, you have the building block, and in between is just a cushion. And then all the way over here on the right is a sagittal of the lumbosacral spine. No different. You've got the building block, and in between each of the building block is a cushion, the intervertebral disc. And this is a T2, so it's a white signal. It's full of water. It's a great shock absorber. This is an abnormal MRI. On the left, here's the normal. Nice contour, nice building block. But look at the left, and I apologize, it's a little darker than I anticipated. But take your attention down here. That's markedly different than here. The things that stand out are the change in the height of this disc, the beer belly or Molson belly or whatever beer you drink. This little white zone, it's not cartilage. It's edema. It's edema of the bone. And we'll come back to that. So let's take the 4 principles of SANA, S-A-N-A, and apply it. So stabilization. You got to think about ligament. What ligaments support this structure? No lecture would be complete without credit to Dr. Hackett. He wrote the defining prose on prolotherapy, which is part of our essential reference material. We utilize this, and I would encourage you to read it. There's the posterior longitudinal ligament. There's the supra and interspinous ligament, which connect the spinous processes. These are all ligaments that have to function for optimal care. Articulation. Well, here we are at the L5-S1. And you can see it's markedly different than the ones above. The disc is dark in color. There's a disc protrusion and some edema. So, the second A, or the first A, is articulation. There's reduction in disc height. The articulation occurs in the lumbar spine in 2 segments. The front portion, known as the anterior. So you got to always look at the disc. Modic, for those people that don't read MRIs, is a type of change on the end plate. But you already see it here. It's just edema. No fancy words. And then there's a posterior articulation in the facet and the SI joint. The next one, alignment, the second A. I just want to take your attention over here and walk down this spine. It would be nice and smooth. Now, unfortunately for this patient, this smooth line doesn't exist because it cuts in and goes around this tree and then goes down the chute. This vertebral body is moved forward. This is an anterior listhesis. So the vertebral body is pushed forward. That has everything to do with part of the problem. And finally, the N, neurologic. This is a simple schematic. On the side, once again, the vertebral body, the shock absorber in between the two, and this is the nerve root. Nerve root, nerve root, nerve root. Well, you can see the nerve root here, nerve root here, but because of this disc is misplaced and this disc protrusion, this nerve root is crushed. Is that going to affect your